seminar today together with Rebecca Ivers from the University of New South Wales. I'll be introducing the topic and Rebecca will be taking the questions at the end. So welcome to the second in our series of injury seminars led by early career researchers. Before we start with this session on preventing childhood injuries in Uganda, I just want to give you an update on the presentation that Med gave. And if Med's online, we want to all congratulate her and wish her good luck. She's about to submit her thesis on Saturday. So congratulations, Med. Med presented last month on drowning prevention work that she'd been doing in India. So this is, as I said, this is the second in our series of injury seminars. And it's really been set up in order to allow early career researchers to share their research and to get input and questions back from you guys on the other end of the webinar. So today we have two researchers we're very excited to have, and I do have to declare conflict of interest here because Olive, who I can see is also on this call, and myself are the principal investigators of the study that Prasanthi and Charles will be presenting today. So this is work around preventing childhood injuries in Uganda, the development of a child safety package using some novel qualitative methodologies, Facebook, for instance, and design theory to actually come up with some engineering measures to prevent childhood injuries. I think they'll also be presenting on some of the novel outputs that we have developed during COVID instead of customary face-to-face photographic representation in a square as we had suggested. So Prasanthi is an injury epidemiologist. She works here at the George Institute at Imperial College with myself. She's done lots of work around child injuries, road safety, lots of M&E work at Hopkins, done some consulting for WHO, and really has wide experience in the area of injury epidemiology. And then Charles Semogabu from Makerere University. Oh, and before I go on to that, Prasanthi is also using this study for her doctorate. Charles from Makerere University is also doing a PhD, not on this topic there. He's doing a PhD on pesticide poisoning, but he has lots of experience around child injuries, published around child injuries, and has a particular interest in environmental modification when it comes to injury prevention. So I'm going to hand over to Prasanthi and Charles. We look forward to your presentation. Thanks, guys.
Thank you, Margie. Thanks very much. And hi, everyone, and welcome to this seminar. Thank you for giving us the opportunity to present this work. As Margie sort of said, I've been in the field of doing sort of child injury work now for a number of years, or road safety injury, and was working at Johns Hopkins before. It's great to see so many familiar names on the call. For those of you who don't know me, or even for those who do know me, my journey for undertaking a PhD has been quite a long one, given that I started my master's back in sort of, 2006, completed my master's. And so you'll know that I've been sort of umming and ahhing about doing the thesis for a long time. But this particular project, led by Margie and Olive Kabazingi, really struck a chord with me, and the stars finally aligned from the project point of view in terms of the topic that it was doing, but also our approach to doing it from a community-based methodology. The funding came through, and from a work-life balance with my two little ones as well. So I finally got round to doing it. So I'm just going to quickly hand over to Charles just to say hello before I launch into the topic. Charles, do you want to just say a quick hello?
Yeah, thank you, Prash. So I'm, as Maggie introduced, Charles, a research associate at Makerere University School of Public Health. And I've been working with the injury research unit at the school with Dr. Olive Kopstinge, I think since 2016, doing some work on an intentional injury, really initial work. And so I was really excited when this idea came around and we finally got the project running. So happy to see all of you join, and looking forward to a good engagement. Over.
Thanks, Charles. So what we thought we'd do is just kind of try and lead you all on a sort of the journey that we as a team led by Margie and Olive took throughout this kind of project over the last 2 years, really, just to give a bit of insight into not only how we had to be sort of quite adaptable in our sort of thinking and dynamic in our thinking, given what we were, the approach that we were taking and what we were finding on the ground from our various engagements with the community, but also to highlight sort of how COVID has affected the work both here in the UK and in Uganda, and sort of the changes that we had to make from that point of view. So just in terms of a quick background, we know globally that more than 270,000 babies and children under the age of 5 lose their lives every year to injuries, the majority of which are unintentional. Sub-Saharan Africa has one of the highest proportions of under 5 deaths in the world. And we know from data that for the most part, for the children under the age of 5, these injuries are occurring in or around the home environment, through things such as burns, falls, drowning, poisoning. And evidence shows from studies that have been done predominantly in the high income countries with Denise Kendrick's team and other teams. I know Michael's on board here as well today. The provision of sort of low cost, subsidized or even free safety equipment coupled with parental education has been shown to be effective in reducing injuries amongst this age group. So what we wanted to do was have a look at what we knew was working within high income settings, and we took this concept of the child safety kit, or as it's known in many countries as the baby box. And just a bit of background in case anybody hasn't come across this before, the baby box is a sort of a social innovation, really. It's a maternity package that is given to mums with newborns as they leave the hospital. It sometimes has sort of well-being things for the new mothers, like muslin cloths, etc. The box itself originally was sort of put on the premise of being used as the crib itself for the baby back in the day when they felt that it would be good from a sort of a prevention of sudden infant death syndrome. Studies for the effectiveness of that sort of shown now that that's not necessarily the case, but the items within the box, which were given from a safety point of view, such as plug outlet covers, baby thermometers, table corners, those kind of things, through studies done in sort of the Scandinavian countries and here in the UK, were shown to be effective. So what we wanted to do was have a look and see whether there was any sort of way in which we could translate this over to the low and middle income settings, and particularly sort of rural settings within low income countries. And so teaming with Makerere University, we've got a long-standing relationship with Makerere, with Olive in particular, working there with them, we wanted to have a look at the following research questions, really, and to try and understand what was the burden of injury amongst this population in a secondary city in Uganda, in Jinja, Uganda. What are the views of the parents? And then working very much with the community and with, sort of the end users of this, trying to find what would be sort of feasible interventions that could go within a child safety kit to reduce the child injuries within their setting. And then try and look at, sort of from a future studies point of view, what would be the barriers and facilitators to conducting an intervention trial, whether that would be possible to do a randomized controlled trial, or whether we needed to look at sort of other ways in which we were going to do this. So we very much took a sort of a mixed methods approach, looking specifically at sort of 3 different objectives: to understand the child injury context, to identify the risks involved with the community there, and then to develop the interventions. So from a quantitative point of view, we did a retrospective hospital data study, and also a community-based household survey together with a checklist risk assessment. From the qualitative work, then we sort of worked with the community to do focus group discussions, and then brought in this Photovoice element of the study. And then we moved forward into working with sort of local engineers and teams to do this, work out what potential interventions would be possible, and do a market survey and discuss those interventions with the community to then go ahead and pilot it. Just a quick sort of brief on where we were doing this study, for those who sort of wanted to just place Jinja. Obviously, sort of Uganda sits next to Kenya and Tanzania here in sub-Saharan Africa, and we particularly wanted to focus on this city here in Jinja, which is a beautiful city. It's known for being the sort of the beautiful source of the River Nile, but it is also a city that has quite a lot of poverty, and sort of you can see here some of the rural settings that we were working within, and these are pictures that were taken by our team on the ground there, just to sort of show you the kind of households and courtyards and communities that we were working within. I just thought I'd quickly put in the COVID slide here. Obviously, over the course of the last couple of years or 18 months, we've been negotiating through this pandemic, both here in the UK and Uganda. Both countries have gone through a number of waves now of COVID-19, which have had that sort of concurrent levels of restrictions and lockdowns. Uganda is now, well, I'm not sure actually currently, but it was about a week ago, in a sort of a state of lockdown still. Which has meant that, you know, we as a team from the UK haven't been able to travel to Uganda since February 2020. And in fact, it was when I was out there in February of last year, and we were in the middle of all the sort of the quantitative and majority of the qualitative data collection, that the first cases from Wuhan were hitting sort of BBC News, and I was seeing it in my hotel room thinking, you know, gosh, here we go. And we've had various team members, including myself, suffer with COVID quite badly at certain times as well, and suffering with consequences of that. So it's had its sort of presence here very much within our project team, but with that we have still been able to collect a majority of our data, majority of which was collected prior to March 2020, but we've had to put in a number of mitigation plans and sort of ethical considerations, point of view of us not being able to travel out there, and so the research team on the ground really having to take the sort of the mainstay of taking the project forward, but also from making sure from their safety point of view and the safety of our community that we were taking the necessary steps. From a methods point of view, this is kind of, you know, obviously the quantitative data that we have done and completed from the hospital record review, the survey and the checklist. With the hospital record review, we selected 4 hospitals in Jinja to try and get a sort of a breadth of the various hospitals and the various access that the community would have. So we have the big referral hospital, which holds about 600 beds in Jinja, and then the sort of level 4 hospitals that were sort of smaller health centres within the sort of the various districts of Jinja. And then there was also a private children's hospital that we were able to go into and have a look. So we trained our field workers on extract data from the hospital registers and the handwritten medical notes and enter it onto our sort of tablet form forms that we had created. And they were looking at all unintentional injuries that came through the underage, under 5 population for a time period that you can see there. We came across a number of difficulties with this part of the study. We have been used to predominantly in the past sort of working in sort of bigger cities and cities that are more used to sort of better patient surveillance, more electronic data records and those kind of things. And what we were finding in these kind of settings was that, you know, we were very much working off patient registers. So as patients came through the emergency department, or into a ward, they were put onto these registers, and these registers had very minimal information about the causes of disease, or, you know, sort of stays and that kind of thing. But we were able to extract some information. But as you can see here from some of the pictures, that the medical record filing system was not necessarily as robust as we would have hoped, so that we couldn't really trace patients from these initial registers through to their more detailed notes. And when we were able to, the notes were sometimes quite scant, handwritten, unable to sort of read it. So we hit quite a lot of problems, which is why we then brought in this household community-based survey, which wasn't actually part of our sort of first initial sort of study plan. But we decided that we needed to get more detailed information and try and get a better understanding of the burden of injuries within the community that we were working with. So based on prior studies that had been done in Kampala, we took a sample size of 615 households over a number of different enumeration areas within Jinja, and we're able to work with our field workers to go and map out the areas, randomly select 17 households in each enumeration area where at least one child under the age of 5 lived, and where the caretaker had sufficient cognitive ability, whether that be in Musago or in English, which are the two main languages there. And here's just a snapshot again of our team working on the ground there and sort of seeing what kind of households they were approaching and how the mothers were sort of engaging with them. And that's our research team in the corner there. From the qualitative data methods point of view, again, we were able to complete our focus group discussions pre-COVID. Photovoice, as Charles will describe, we had to sort of take a bit of a hiatus in because it just got too unsafe to be able to keep that study going through the COVID sort of lockdowns that we were facing. And we're currently at the process of doing these sort of co-design workshops with our engineers, we will talk about. So with the focus groups, we again, whilst I was on the ground in Jinja, trained research assistants to be able to conduct semi-structured interviews. And we purposefully selected people to be within 10 different focus groups. And you can sort of see there that we took a bit of a wider breadth of maids, mothers, local counsellors, teachers and village healthcare teams, just so that we could really engage with as much of the community as possible to try and understand what we were dealing with on the ground there. Charles, did you want to talk about the Photovoice component?
So in order to deepen our understanding of the drivers of the unintentional injuries among kids in homes in Jinja, we undertook the Photovoice exploration, and with the thinking that it would also bring out the actual, injury scenarios or situations in homes. And so we identified about 20 mothers that had participated in the focus group discussions. And then we went ahead to select 10 from those 20 that participated in the focus group discussions. And these, the selection was largely based on their age, the parity, marital status, the villages under which they stayed, but also the opinions of the community leaders that knew them. And then so after the selection, we were able to train them. And the training largely focused on the themes of the area of interest for this particular study, and in this case, a lot focused on the behaviors and practices in households that could, expose kids to injuries, but also the physical environments in the homes that could also put them at risk. And the training was more of an engagement where we first listened to these mothers to tell us, what things do they see that could put kids at risk in their homes, and then we built really on their ideas on those themes. But we also introduced them to, of course, unintentional injuries and the burden in Uganda, but also the major types. We also had to train them on camera use and care, especially that, some of them had not, used cameras before. and also the ethics of photography to ensure that whatever that they were doing in the community was not going to cause issues or problems within the community. And so after the training, we gave them cameras and asked them to take photos for 2 weeks. And then we would invite them after those 2 weeks for us to meet and discuss the photos. But unfortunately, during that time is when Uganda registered its first case of COVID. And so we were not able to proceed with the first meeting. And so we first let them continue to take photos for a certain period, but then later with consultations with a bigger study team, realized that maybe we could stop them a bit, given that it was a very challenging time, in the lockdown and all kids at home, and the environment was not really, maybe would influence our study frequency. But then in June, when the lockdown was lifted, so we resumed the meetings, and so we had 4 fortnightly meetings in between, of course, periods of them taking photos. And these meetings were meant for them to bring the photos that they had taken during that period of 2 weeks. Then we would get them from the camera, of course, with and ask them which ones they wanted to talk about. And so we'd select those, put them on a laptop, and then projected them. And every mother was given an opportunity to talk about the particular photo that they had brought. And again, amidst those meetings, so we used to hold some preliminary analysis after each meeting, and that analysis was meant to identify any issues that could have come up in the previous meeting that probably needed follow-up in the next meeting. And so that's how we were able to execute that. And in the photos there, you can see the 10 mothers that participated with other members of the research team. And then the other 2 photos is really showing mothers in action, of course, trying to social distance and wear the masks because of the COVID, but also making sure that the work continued as planned. Over to you, Prash.
Thank you, Charles. So I don't want to spend a huge amount of time going through the quantitative data, because Charles and I kind of really want to focus on what we were finding with sort of the community engagement. But just to say, so from the hospital record review, we were, despite the sort of the difficulties in extracting the data, we were able to identify 235 cases across the 4 hospitals, 58% of which were of male children. And the predominant injuries that were coming out from this were 34% for burns, and then we had cuts and concussions, presumably sort of from falls or from unintentional trauma. We weren't able to sort of get true data on the sort of the actual nature of the injuries, but we looked at treatment outcome and length of stay. The majority of patients were treated within outpatients or admitted to the ward, and across those 235 cases, there were 7 deaths reported, but the majority did recover and were sent home. The household survey, we were able to identify 615 households, which resulted in a population of our under 5 children being 879 children. Of those 879 children, there were 524 children who had been reported to have suffered at least 1 injury. And so in total, we had 871 injury events that we were able to collect. And if you can see here, the majority of them, of the children, suffered 1 injury, but the rest, there are, sort of a number there where there were 2 or more injuries. Looking at sort of incidence rates, we actually ended up getting quite a high incidence rate overall of 596 injury events per 1,000 children per year, which was higher than previous studies in the area. And we sort of put that down to the fact that we were sort of quizzing. A lot of the previous studies have been using hospital data and registers from primary cities, and so we sort of anticipated that this was a lot more because we were capturing more of even the milder and the moderate injuries that may not have gone to sort of access healthcare necessarily. From a location of injury point of view, you can see here that the majority happened within the own home environment, with 53% actually happening within the immediate vicinity, the outside vicinity of the own home, whether that's the courtyard or the sort of the lawn area, or even just sort of the road right outside the house, and then the 36% were inside the house environment. And from the community-based survey, the majority of injuries that we were finding from this were due to falls. That was falls due to falling off beds or falling off verandas where there were no guardrails or balconies, and the rest were due to either burns from stovetops or from hot water. And then 10% were due to being unintentionally struck or hit by another person or an object. So when we looked at risk assessments, the risk assessment checklist, so I didn't really talk about it when we were doing the methods, but essentially we had sort of developed a checklist in collaboration with our extended team, with the Johns Hopkins team had done this previously in Malaysia, and so we took the checklist that had been done there and adapted it with our team on the ground in Uganda to sort of make it more specific to the Ugandan housing setting. But the research assistants who were the field workers were able to go in and with permission from the household members, go and look for specific hazards that we had identified for the various kind of rooms within the house. And we did find sort of an analysis that there were associations between certain hazards and causes of unintentional injury. For example, when there was carpeting beneath the surface on which the child sleeps, or some kind of protective surface underneath the bedding, there was less of a risk for fall injuries or injuries being sustained from the falls. And similarly, when there was a separate kitchen or when the child was not within reach of matches or open fireplaces, that was associated with a lower risk of burn injuries. So then we moved on to the qualitative data and the focus group discussions, and it really highlighted to us actually when we were doing this that the importance of mixed methods approach and the importance of being able to do qualitative data. And we very much, tried to do this in a sort of an iterative dynamic process whereby we were taking what we had found from the quantitative data and using that to sort of guide our focus group discussions, but really sort of trying to engage with the mothers and the maids and the various kind of village health teams that we were talking to sort of get their perspective on what was happening on the ground. And so we very much kept it as open as possible to allow sort of themes and context to come out that wouldn't necessarily have come out from the community-based surveys and risk assessments that we had done. So looking at sort of nature of injuries, whilst I'm talking, please do read the quotes. I won't necessarily talk, sort of read out the quotes themselves, but we were finding that predominantly children were falling off beds, which had come up in the quantitative work. A lot of these households had, sort of living spaces that were doubling up or tripling up as the kitchens and the living space and the bed, the sort of the sleeping areas. And so in order to save on space, most of these families have double or triple decker metal bunk beds, and quite often there are no guardrails. And so the falls that were being reported were those that were falling off these triple decker beds onto hard concrete floor. But as came up in discussion, even when there were guardrails present, they were seen to be a hazard, either because the guardrails themselves were too far apart, and so children were getting stuck and hurting themselves in between these guardrails, or they were sharp-ended, and so they were getting cuts and piercing themselves on the top of these guardrails. And so quite often, even in the presence of a safety device on these beds, they were causing injury to the children. And the other fall that came, cause of falls that came into the chat, which we hadn't thought about necessarily when we were doing the community-based survey and the hazards risk assessment, was falls into the pit latrines, which were within the compounds. And these were big holes that were obviously sort of dug into the ground from a sewage point of view, but are sometimes covered over, but quite often not. And even if they had a cover, that was generally a soft kind of banana leaves or kind of thing to cover the floors with. And so children were commonly falling into these pit latrines outside. From a burns point of view, again, we had a checklist and survey had sort of reported as well on hot charcoal stoves being a common form of reported injury. But again, from our focus group discussions, what we were finding was that it wasn't just the presence of one hot charcoal stove in the kitchen. A lot of these households had sort of a number of different stoves on the go at the same time within a small area. And so what was happening was that the mothers are used to, and their sort of their hands would be hardened and used to being able to just pick up a hot charcoal from one stove to throw it to another. And so there was a report from the mothers of children mimicking their mothers by throwing charcoal from one stove to another and therefore getting burnt. But a lot of these burn injuries were being attributed to lack or limited supervision by the parents or the caregivers, or forgetfulness when they were sort of, you know, trying to do a number of different things and multitasking with numerous children or elderly people within their household that they were all looking after. They quite often would leave hot water from saucepans or basins within the vicinity or the reach of a child. And quite often, because there were so many people living within a household, they would have just an ongoing pot of porridge on the go, and the children who were hungry would just, as you know, well know with children in that age, if they are hungry and they need food, they will go for it and go and put their hand into those hot pots. The other burn injuries that were coming up, again, were related to the paraffin lamps or the tadobas in the households, and there were reports from some of the mothers and the maids. These paraffin turned on, and they would be wafted in the wind, and the mosquito nets would come and actually sort of catch fire, and then the mattress would burn, and the child would burn as a result. Something else that came up from the focus group necessarily noticed the risk assessment checklists or from the community-based survey was, and this was generally due to the combination of poor storage. They didn't have facilities to be able to store their sort of chemicals or their bleaches that they were doing. But also what came up was the misuse of drugs, and particularly both ways, maids were sort of complaining about their owners or their bosses sort of having recreational drugs or alcohol lying around that children could get their hold of, and vice versa. There was also reports from village healthcare teams of sort of saying how quite often the maids would all get together and be, you know, sort of maybe drunk or leaving bottles of alcohol around. And the other thing that came up was that quite often in these communal courtyards, due to the nature of the jobs that the men in the households were having, there would be quite often building materials and cement bags being left within the courtyards within easy reach of the children. And the other thing that came up as well was, I should have mentioned from the burns point of view, sorry, that just reminded me, was that these courtyards where the children played from numerous different households would also hold the be where the motorcycles would come and be parked. So the men would come back on their motorcycles or on their bodabodas and leave them in the courtyard, and the engines would still be hot. But the children wanting to come and explore their motorbike and sit there and get burnt from the engines of the bodabodas. The themes that really came up from a sort of children's behaviour point of view, revolved around curiosity, exploration and mimicking, some of which I've just sort of talked about there. Being curious about sort of the substances that were being left around the house, exploring around the garden and falling into the pit latrines or touching the hot engines of the motorbikes, and this notion of mimicking their parents and wanting to take sort of sharp implements and to help peel the vegetables or throw the hot chocolates sort of from stove to stove. And so these were some of the sort of the comments that were being made by some of the participants in our focus groups. And there was quite a lot of chat as well about children wanting to eat things and put things in their mouth, and sometimes that would be the notice of sort of poisons within particular flowers or plants within the courtyard. When we explored adult behaviour, a lot of the themes that were coming out from our analysis were to do with supervision or negligence, knowledge, both from a point of view of risks and what was considered a risk. A lot of sort of parents or maids weren't necessarily aware of the risk of fall injuries or hot water or even sort of electric burns that were happening. But also from a point of view of sort of storage of chemicals, and from a knowledge point of view of where a child was at within their developmental stage, and sort of expecting quite a lot of young children, not in sort of expecting them to understand the risks and sort of for them to be able to stay away from things, but also expecting older siblings to take over the younger siblings' care and not necessarily realizing the sort of the abilities of the children from a developmental point of view to be able to do that. And the other big sort of theme that came out was that of blame shifting. Both ways, again, mothers and owners, sort of household owners, blaming the maids for not really taking good care of their children whilst they were away. But also from the maid's point of view, for sort of saying that they were left with too much responsibility, too many children to look after, and being expected to do household chores and do the shopping. And so quite often they would have to leave to go to the shops, but leave the children unattended, because if they didn't, they would get into trouble with their owners when they came back. So there was quite a lot of discussion about supervision of children and this notion of needing to leave children with the younger children with their older siblings, and trying to understand that sort of notion of when a child was particularly old enough or responsible enough to be able to take that on. And then again, here's a quote that sort of shows that knowledge and awareness of where a child's development is in terms of their age, and shifting that blame onto the child rather than taking the responsibility of the adult. And then this one was really the crux for us in terms of really having to shift our thinking from what was going to potentially be interventions that we could put within a baby box, and seeing that lack of space and finance issues and healthcare access were real factors that were coming up. And I think Charles will talk a little bit more about sort of lack of space and sort of other social determinants. But we very much sort of felt that things that were coming out, focus groups were showing us that, you know, a lot of these families were not able to afford other means of childcare or afford to have bigger houses or organise their sort of possessions in a more sort of safe manner, when they couldn't really even afford to be able to send their children to school and needs. Charles, I'm going to hand over to you to do the Photovoice component.
Thanks. So from next slide. From the Photovoice analysis, we found a bit of what is actually Precious talked about in the focus group. But as you could see from the first photo, is a child who, you know, was probably trying to cook, and it appears that probably the mother had just, stepped away in a minute, and then the child, moved in to try and see, what is going on in the saucepan, and this could probably put her at risk of, this puts her at the risk of being injured. So again, speaking to the inadequate supervision that happens in the homes, but also a bit of negligence, and again trying to mimic the mother and being curious, and so on. Then in the next photo, also you see that a child is trying to hold a panga, even on the sharper side of it. And I guess, she or he had just seen a mother or a father doing just the same thing. And of course, this panga being left there unattended to, probably led into this. And of course, this also puts them at risk. And so this speaks to, some of the practices in the homes, especially, to do with the storage of these hazardous items in places that children can actually get access to. Then we also found themes around social determinants of health and inequalities, and so things to do with lack of space. People in many of these communities actually live in a kind of a slum setting in very small units, and end up having to fix every little thing within their small units, and so in this quote, a mother is talking about a house that was really, really packed, and so a child could access anything within the home, including those that could put them at risk of getting injured. And then in the other photo, you see an old structure that has a very, raised base or balcony, if you like. And, kids are just playing over there, and this actually has any guardrails. And so this place is really unsafe for kids to play, and speaks to, the very many unsafe environments in which kids grow, struggle to live in, and then eventually getting injured. Then we also found a theme on unsafe energy use for cooking and lighting, and you can see that many of the households use the charcoal stoves, and these can easily burn kids if they get access to them, but also put the house, or especially those that were cooking from the houses of the landers, at risk of having fires burn the house, or even kids. And there have actually been cases in this community. And the other also comes to poverty, and in that second photo you can see that these people are living in houses that are made of, temporary materials, and then, iron sheets and wooden stuff. And these, of course, again, put kids at risk of injuries, especially cuts and so on. But also in that photo, you see that this is probably a bathroom or the washroom. And, it has a soakaway pit that is inappropriate, where the water actually just collects. I don't even think this is a soakaway pit, but it's probably where the water drains. And of course, this also puts kids at risk of injury and even drowning, as, earlier presented that, many of the falls were actually kids falling in pits, and this is evidence of what could be going on in the community. So, as Prashad earlier said, that we had intended to come up with a child safety kit, But after these preliminary findings, we actually had to rethink our path, and so we had to find better ways of trying to look at what can we do to help or reduce the injuries in this community. And so many of the risks actually required a bit of environmental modification, which would not necessarily fit into a kit as we had earlier thought. And so we had to think about trying to find what can we do in the environment. And so we identified a group of engineers and architects and some urban planners called Design Without Borders that we thought we could work with and try to develop some of these interventions. And so we presented to them our preliminary findings, and also, shared with them, our thinking in terms of the, initial ideas and where we want to go. And so Design Without Borders then suggested a 5-phase approach using the human-centered design. And so this, of course, involved research, where, of course, they reviewed our preliminary findings report, but also undertook some household survey, really very, few, household visits for them to really get to the ground and see what exactly we are talking about. Some unstructured interviews with the people that they met in the households, but as well as observations. And I think they also held a workshop with community members that we identified for them. So about 10 of those, and these included, parents, a mix of mother and the father, siblings, some teachers, as well as community leaders. And so they tried to gather more information to supplement what we had. And then from the research phase, they then went into we then went into ideation, and this, of course, involved research synthesis, so trying to triangulate all the ideas. And then we went into building the design criteria, and then brainstorming ideas, and then sorting ideas. And then after that, we went into conceptualization, and this involved refining and narrowing down ideas, trying to build preliminary mock-ups. And at that stage, then went into prototyping, which we are currently undertaking. And then after prototyping, then we would go on and test these prototypes in the community. So these are the 5 interventions that we zeroed down to, and of course these are informed by our preliminary findings. And so the first one is the cooking cage, that is aimed really again at trying to see that you reduce the child accessing a cooking place or space or source of fire. And then there's also a fixed cooking station, and these have been some used in the community, but now this has been a bit more modified. And again, like we said, we use the human-centered design where we engage the community and trying to go back and forth and ask them, so what is there, what can we do? So then this is one of those that is a bit modified. And then down here is the outdoor cooking ring. And of course, this is also informed by the fact that there are many households that actually cook from outside, but also kids do actually play from those outside environments. And so having an outdoor cooking ring would help prevent kids from falling into these spaces. And the fourth is the multi-purpose mat. And this is again aimed at trying to ensure that kids have a safe surface at which they can play at. But this mat can also be used for preventing other possible injuries, like putting it under the bed in case a child falls, they will definitely fall on the mat and so on. Yeah. So the last one, which is not presented here, is the chopping board, which we hope that we can use as a chopping board, but also use it to keep sharps, like the knives and other cutlery within the house, whose mock-ups are still, sketches are still being developed. So that is, where we are with environmental modifications. Over to you, Prash.
Thanks, Charles. I'm aware that we've not got much time left for questions, so I'm just going to leave this slide up here, which essentially just shows some of the sort of the photographs that the mothers had taken from Photovoice that we then developed with the community to then make sort of safety messages over the festive period with them, and this went out to a lot of the community that we were working with. But I'm going to leave it there, Rebecca, because I know that we've not got much time left, and I would love to field some questions from the audience.
Thanks so much, Prash and Charles. That's fantastic to hear the work, and I do also have to declare a conflict because I'm also associated with this, and it's really great to see the way that this has evolved. And really, I mean, it's so important though, the work that this has come directly from the community and addressing community priorities and co-designing the prevention with the community, and it's being led by them. And when I think also about what this project actually looked like at the start, it's actually completely different. It's completely turned around, and that is completely appropriate because this is what co-design really is from a community perspective. So well done everyone. And Charles, fantastic, great work. Now we do have some questions. Prash had answered them already. I think there was a question about the justification for the time frame. Prash, you may as well just answer that again briefly.
Yeah, so the question was, why did we pick that sort of specific April to September 6-month period? And a lot of it was because we wanted to get a consistent time period across the 4 different hospitals, but their sort of ability to provide us with registers, etc., were sort of balanced by the fact that a lot of the time it would take quite a number of months for those registers to make their way to the sort of the reporting room or the sort of the file area in the hospital. So we needed to make sure that we were being consistent across the different hospitals. Some of them are much more efficient, but we also wanted to capture sort of that sort of period of time as well from a sort of a seasonal point of view as well. So it was just sort of felt that 6-month period was probably going to be, and also it was 6 months rather than any longer because it was just taking that much time to extract the data from these records.
Yeah, and look, there's another great question here from Jagno, and I know she asked that before. She asked about the cost perspective with the prototypes, and she's saying most risks around the social determinants of health. So the cost? I guess the question is, how costly are they, and how cost efficient are they going to be? Yeah,
so thanks, Rebecca. That's kind of where we're at the moment in terms of trying to figure out how we can move forward with this. And we did have just about enough funds to be able to carry out the initial prototype development. Our original plan had been to be able to get through to sort of piloting those within the community through this grant, but we've actually now, with a combination of COVID and sort of finances, we've realised that we're going to have to probably merge that one into the next full grant and sort of get to the point where we're at now to sort of say, these are what we would like to test. But we're really trying to work with local carpenters and skills that's within the community, sort of from a micro community point of view, to be able to do that. And also just to answer your question about social determinants, Jagno, as well, we were, we've had to sort of obviously think outside this box and look at more substantial interventions, which may well, again, be a sort of microeconomy point of view, getting some of the local communities, some of those maids to work together to provide sort of supervision in terms of some kind of crash facility, or there are, as we're coming across through it with engineers, community centres that the older children, the sort of 17+ year old children, were using to get together and do sort of social activities, whether that was create their own plays or play football or, you know, do these kind of things. And so there might be some ways in which we can engage with those groups as well.
I think that's great. I think I'm really interested also, Charles, in hearing from you about the question of supervision, because I noticed in some of the slides with the qualitative data that it seems to be, you know, it's very negative connotations about the parent not supervising the child, the negligence of the parent, when in fact, in an environment like this where you've got crowded households and stoves like this, you know, it's not about bad behaviour. It's just about, and it comes back to the social determinants, just about the structural, you know, the structural barriers to safety rather. And so I wonder about the messaging here, how you address that without actually stigmatising or criticising parents for lack of, you know, for not supervising children appropriately. I think it's a really tricky area.
Yeah, it is. And in fact, there is, you know, in this area, there is supervision that you can do, but there is so much supervision that you can really do when everywhere you turn is a risk and so on. So, and it really, you know, came out very strongly. And I remember even in the Photovoice, a lot of mothers, you know, kept, you know, shifting the blame and saying, oh, no, that mother was not serious. How could they leave a child to go and play the other side? But, you know, it's the mother also is the same mother has to fend for the child and so on and so forth. So it's really challenging to, you know, how much supervision a mother who has all that, you know, those roles can do. But I think that you know, a combination of interventions could actually then help, you know, boost, you know, the supervision, the little time that the mother has to supervise and ensure that, you know, the injuries or the injury risks actually be reduced.
That's right. Now, Prash, do you want to stop sharing your screen so we can see you and Charles? That might be good. A question from Julie Bitten, and she's asked you to talk a little bit more about how the photos were analysed through the workshops. Were they used as a trigger for discussion so that the workshop was analysed as a focus group?
They very much were, Julie. So what we would do, and in fact, you know, again, because of COVID, this was very much led by Charles and the team on the ground. But it was essentially each time they came together was used as a focus group, and the session was recorded and analysed, and then the findings from that were then taken to sort of then feed into the next group setting, and it might be used to guide the discussion a little bit more. But I have to say, you know, from sort of knowing what the team are like, they were just brilliant at being able to not actually force conversation from previous groups, but just sort of guide the mothers to be able to sort of say, okay, well, I remember you saying this from last time, or there was, you know, there was an element of this discussion in the last group. Has anybody seen that in the subsequent 2 weeks? You know, that kind of thing. So it very much was kind of used as a dynamic analysis and feeding it into the next focus groups.
Yeah, and maybe to just supplement that, while every mother brought in a photo and talked to it, other mothers were also given an opportunity about that particular photo, if at all they actually had another angle in which they were, you know, viewing it. So, it was really, again, you know, used to stimulate, but again, you know, after we have transcribed and then we analyze, so we try to link the photos again to the quotes and so on. So the sources of data actually both the discussion but also the photo themselves.
Okay, thank you, Charles and Prash. We're going to have to wrap up. It's 7 p.m. here in Australia, so those of us in Australia, need to go and eat our dinner. You need to all go and get on with your days or have lunch or wherever you are. So thank you so much, everyone, for joining. Thanks, Prashanti and Charles. That's just been a fantastically useful and interesting presentation. Really wonderful to see the development of that in this co-design process. And I think use of Photovoice as well, they're sort of innovative use of, you know, new methodologies, and, you know, really it's really good to see how it sort of brings out the important aspects of the community priorities. I just want to encourage everyone to come along next month. We'll be sending out the invitation soon. Very excited to say we have two researchers from Nepal talking, Santosh Bhatta and Preeti Gautam, who are going to talk about the development of the, I mean, many of you will know about the Nepal Injury Research Centre. So they're going to be talking about some of the work that they've been doing there and policy and how they're translating that into policy and practice. So thank you, everyone. We've recorded the seminar, so I think we'll be sharing that as well. Really hope you can come along. It's great to see such a wonderful audience here and everyone actively participating. So thanks very much again from Margie and myself, and we really look forward to seeing you all next month. Thank you very much.
Yeah. Thanks very much, everyone.
Thanks, Prash and Charles.
Thank you, Maggie.
Ciao.